Morning, everybody, or day or evening. We'll start in a little bit. Thanks for joining. Well, hi everyone again. Thanks for joining. We have a few people still filtering in, so we can maybe take another minute. In the meantime, obviously we want to recognize all the fellows, especially the graduating fellows of neurointerventional or neurovascular, or whatever our diverse field calls itself. Obviously it's a ton of commitment and hard work, and our field is constantly transforming and expanding, and so are our working hours and what we do. So yeah, thank you for everything you do. We're here. Essentially, the biggest part of, I think, what we do is really education, and education for everybody. Education never stops, of course, and this and that, but specifically related to the fellow experience. I think that's our mission. So we thank you, and we're, it's a privilege to be part of it. Anyway, we want to focus on the fellows today. So we have a couple of, you see the people that have some presentations that they're going to give in no particular order of preference. If anybody has any timing commitments or whatever that would require you to present a particular time, maybe you could let us know in the chat or anything. So that you could get to present. But we'll focus on these presentations, and if time allows, if there's anything else, we'll do that afterwards. So without further ado, Gurmeen, good morning. I see you logged in. Can you hear us?
Yeah.
Excellent. All right. Let me stop sharing the screen. Can you go ahead? So if you're ready, let's get going.
I'll have to log in again. It'll take me like 30 seconds.
Okay. All right. Take your time. Let's do Daniel, you can go second. We are, we too, as you all know, as we announced last week, we are, after this session, we'll have another session. Next week, there'll be another session, a welcoming session for the incoming fellows. Following that, we're going to go to a once per month or a monthly schedule as opposed to the weekly schedule, just reflecting the realities of, restarting a life, at least in New York. I know that's not the same for other people, but for us, for the time being, there is stuff to do. All right, great. We can see your screen. Go ahead. Gurmeen, I don't know if can anybody hear? You might be muted, perhaps. Let me see.
Can you hear me now?
Yes, we can hear you now, and we can see the screen. So that's great. Maybe.
Okay, perfect. So the first part of the topic would be idiopathic intracranial hypertension and what we know about venous sinus stenting so far. So basically, venous stenosis has been believed to be a cause or a repercussion of idiopathic intracranial hypertension, and the stenosis is either both transverse sinuses or the dominant one. And it can be two patterns of stenosis that have been described in literature: the extrinsic, in which there is smooth, narrow, tapered stenosis, and the intrinsic, which is thought to be because of fibrous septae or arachnoid granulation sort of within the venous sinus. So, it's a chicken and an egg question. Is stenosis the primary cause of elevated ICP, or because of elevated ICP, there is stenosis? And there are two distinct populations with IIH. One who have true IIH, truly idiopathic, and second, IIH that is caused secondary to venous outflow obstruction. This is a nice diagram showing extrinsic stenosis at two distinct points in the venous sinuses. I found this like really interesting study. This was published in Neurology a couple of years ago, where in a study with 51 patients, 100% of them had transverse sinus stenosis. So every single one of the people enrolled. And 71% of those 51 actually had more than 50% stenosis. So management options, now there are a varied options, but I mean, we're going to concentrate on venous sinus stenting, but optic nerve sheath fenestration performed in emergencies. But the point to note is that the overall complication rate is about 18%, which is not insignificant. Same holds true for CSF diversion techniques. Serial lumbar punctures are useful for fulminant IIH for the short term, but they're not a durable long-term option. VP or LP shunts have a complication rate of nearly 45%. And they do cause symptomatic improvement, but long-term success has not been very convincing. So how did venous stenting come along? In 2002, King basically removed 25 ml of CSF by a lateral C1, C2 puncture, and there was immediate resolution of venous hypertension. And that led to the first venous sinus stenting in a patient in 2002. An important thing to note is the pre-procedure manometry showed a pressure gradient from 18 in the transverse sinus torcula was 27 and the jugular pressure was 9. So the gradient was more than 8 to 10, which is the considered the sort of cutoff for when somebody should be stented versus not. And then after stenting, the pressure differential between the torcula and the jugular bulb fell from about 18 to now 3. This is a diagrammatic representation of what venous stenting is basically doing. So in the last decade, there have been like multiple studies on the efficacy of venous stenting as a treatment for refractory IIH. MRV has been found to be a very good screening tool and has a specificity of 93% and a sensitivity of 93%. So if there is bilateral or unilateral stenosis in a patient who's medication refractory presenting with IIH or is not able to tolerate Diamox for medical reasons, then the first step is to proceed with diagnostic cerebral angiogram and do a pressure gradient measurement. The pressure gradient is basically measured along various points in the venous system, starting in the superior sagittal, then the proximal, distal transverse, pre and post stenotic segment, as seen on venous angiography, and then also the torcula and the sigmoid sinus. And the pressure gradient threshold for treatment is about 8 to 10. Though there have been studies that have shown that even with a pressure gradient of less than 8, patients do benefit. These are a few examples of venous catheterization. So this is, we're going through the external, internal, and then catheterizing, and you can see our arterial catheter in the bulb of the carotid. And here's another one showing canalization of the sigmoid sinus. And this is with an IVUS probe, which I will talk about in a bit. So venous stenting patient selection. So this is a study showing the pressure gradient of more than 8 in a sort of cohort of about 60 people. And whenever the pre-stenotic to post-stenotic or the transverse jugular gradient is more than 8 centimeters of water, those patients are the ones who will potentially benefit from getting a venous stent. Another example angiographically showing venous stenosis. Another thing which is important to note is that opening pressure is a very strong predictor of who is going to have a higher gradient. and the chance is significantly increased. So every 1 increase in centimeter of water opening pressure, 14% increase in the chances that the venous this difference would be more than 8. Another example. So the treatment protocol. So most patients are pre-treated with aspirin and Plavix for 7 days. Femoral, arterial, and venous sheets are placed. A microcatheter with a microwire is used to access the superior sagittal sinus. Arteriography is performed, a venous roadmap is obtained, and then a pressure transducer is attached to the venous microcatheter for venous pressure measuring. And then pre-stenosis and post-stenotic pressures are obtained. And if the pressure difference is more than 8, then the plan is to proceed with stenting, at which point the patient is anticoagulated with an ACT goal more than 250. And the deployment of stent, and that's, I thought, the key feature is it has to be more than 10 millimeter from the point of stenosis. So the longer the stent, the better it is, because there is very high incidence of stenosis sort of exactly where the stent ends in case the stent isn't long enough. And then continue dual antiplatelets for 1 month, and then aspirin for 3 months. And in case there is worsening, then to repeat an angiogram to rule out juxta-stent stenosis, which happens to be the most common complication that is encountered. This is another example of manometry tracing, a reference venogram from a case, showing that pre-stent the pressure was 39 and post-stent it dropped down to 19, similarly with the left transverse and the left sigmoid sinuses. So unilateral venous sinus stenting is performed more commonly, even if there is evidence of bilateral stenosis. If there is bilateral, then the greater degree of stenosis or the dominant sinus is stented first. In an interesting study, the conclusion was that there are only select microcatheters that can be successfully used for venous pressure manometry: Echelon 10, Prowler Select Plus, and Marksman 27. SL10 was not recommended, did not meet the standards. Antiplatelets we talked about, so aspirin and Plavix both 3 to 5 days before, and then dual, some say 1 month, some say 3 to 5 months. But with single antiplatelets, in-stent thrombosis is seen more commonly. The type of stents multiple stents have been used. There are ongoing trials for the River stent and the Zilver stent, but there are other stents that have been tried. The number of stents used, so there's no consensus on that. Most people use 1 stent in the first go. Some studies report up to using 1.4 stents per stenotic segment. The use of intravascular ultrasound is an interesting adjunct to venous manometry, and it can help differentiate extrinsic from intrinsic stenosis, and it can help visualize arachnoid granulations. This is an example of IVUS done at our center, and you can see the pre-stenotic area, the stenotic area, and then the post-stenotic area. And the area basically tells us that the stenosis is of significance. This is a video showing the same thing. Okay, yeah. This is going through the torcular, distal transverse, proximal transverse, sigmoid sinus. In the detection of restenosis, which happens to be the most common complication of IIH, MRV has nearly 100% sensitivity and specificity. So these are some of the recommendations, and I'm only going to emphasize on the ones that are moderate to strong. So image-based selection, it is reasonable to use non-invasive venous imaging as a screening tool to determine which patients should be taken for venous manometry. Venography should be performed to assess candidacy. Diagnostic venography and manometry should be performed with the patient awake. Ideally, if you can get the patient to Valsalva during the measurement, that's even considered better. Antiplatelet regimen should be started before and should be continued for 3 to 6 months following stenting. And post-stenting manometry should be performed at the end of the procedure to document that there was actually resolution of the pressure gradient. Also, it is reasonable to repeat angiography and manometry on patients with recurrence of symptoms after resolution of stenting. That's all I have for IIH. I'd be happy to take questions. I have a small section on MMA embolization. If you want, I can just continue and then take questions at the end.
No, why don't we, maybe what we can do is, let's take questions now for this, since I think it's certainly is a separate topic, and probably there could be a lot of questions. Thank you so much.
I have a question. Tibor here.
Tibor, good morning.
Yeah. Hey, Max. So it's very interesting. So I remember in our early experience, we used to do the manometry, and then we kind of stopped doing it. And the question is how did they come up with this, this cutoff of pressure gradient that is the recommendation, and how official is this recommendation? Because the last few cases I've done, I really didn't measure because there's obvious stenosis, obvious symptoms, especially if the symptom is tinnitus, and just went ahead and did the stenting. So it's curious to see there's a solid number recommendation, and how did they come up with that? Do you know anything about that?
I think it was from those opening pressure studies initially, and it's an arbitrary cutoff. And there are studies showing that even with people who have less than 8, if they are symptomatic and they get stented, they do show improvement. So there are a couple of studies I found that suggested stenting even at 4 to 8, but the number is actually pretty arbitrary.
Mm-hmm. Okay, thank you.
Somebody's asking about microcatheter versus intermediate catheter. Some believe measurement is more reliable. In all of the literature review I did, I just found the one that I showed you, that these specific microcatheters are what are recommended.
I think it probably just has to do with the diameter of the catheter.
Right.
Not the catheter itself. The related question is, once you get a big enough catheter, the catheter itself increases the stenosis, of course, at least on one side. So
right.
It becomes the question of what to do. We've used a pressure wire. There's cardiology uses pressure wires. They have other reasons for doing it, but we've used that, and we've used the catheters. I'm not sure if it makes a big difference which one you use. You definitely, from the cost perspective, the catheter, you've probably already opened it.
Right.
I'm sure there's a lot more. For me, I've always had a lot of questions about this. I know Higgins for a while, and he's been proposed, like he's been a champion of this from many early days. But it seems like the acceptance of this, at least in the kind of neurology, neuro-ophthalmology community, is very patchy. There are believers in this and non-believers, despite this sort of there's definitely pockets of belief and performance here. But it's been a little bit, it hasn't really been uniform. What do we think about that?
Yeah. Even at our own center, we still been trying to get people on board with it. Everybody doesn't refer patients for it, and then the ones who are fulminant anyway end up needing high volume LPs, etc. So it's not an emergency sort of treatment. So it is still gaining momentum, but the hope is MMA embolization picked up in the last year. The hope is if we talk about it enough, then at some point people will start actually referring patients.
It's been, there's always been a lot of questions. we don't really understand why. I feel like. And then that question you raised, like the durability of the treatment, all of these I think remain open. But it seems like, as you say, the momentum is forward. So
Yes.
we hope that,
The big question is, is there any data on long-term effectiveness?
There are studies following patients up to 2 years, and I think the most common thing that they encountered, which was a problem, was the juxta stent stenosis, more in the earlier studies. After that, I think people started doing like longer stents extending from the torcula all the way into the sigmoid sinus, and that somewhat reduced the incidence of the juxta stent stenosis and decreased the overall complication.
So it's interesting because if you say, okay, the IIH is, if you hypothesize it is the consequence of venous, or I mean, the venous stenosis is the consequence of the IIH, or of the elevated pressure, right? If you relieve the pressure by stenting the thing, you know, why does it re-stenose?
That's where the extrinsic theory of why venous stenosis because of external pressure sort of weighs in. I'm not sure we completely understand it,
Mm-hmm.
but that's sort of the proposed hypothesis for why it recurs.
Mm-hmm.
I think people hold very strong opinions about whether it's extrinsic or not.
Yeah.
There are those that would cite and say, well, how come people with intracranial tumors or other conditions that would cause, elevated pressures are not encountering venous sinus stenosis to the same extent? So there's thoughts on both sides. You haven't mentioned something that I think has recently also emerged, which is undersizing the stents. So longer stents, and also that are not actually sized to the diameter of the sinus or whatever, to use something a little bit smaller.
Yeah.
Might be associated with less recurrence, but we don't not sure if that's understood why. Kitty Pong is asking a question. Why do we have higher complication rate of VP shunt in this group of patients? Kitty Pong, higher compared to what?
Well, I don't know. It's like, I don't think it's something like what we see in the Van Galen in pediatric population, because of the CSF absorption mechanism is probably different in adult and in infants. But I saw a very high complication rate in your review, up to like 20% or something. Yeah, that's really really high. And what are the complications that was? Did you know what were the complications? They mentioned anything about that?
No.
Or
I mean, I can hypothesize that these are the patients who are less compliant with medication, or just have either the VP shunt is put in an emergent setting, or it's just because their habitus makes, shunt block easier. I don't know. I'm just hypothesizing. I don't have a good answer.
Right. Thank you again.
Hold on, Max, I have a question.
Yeah.
You use almost interchangeably centimeter of water and millimeter of mercury. Can you I just want to make sure we have one good number.
Centimeter of water.
Because they're not really the same.
Okay. Yeah. Centimeter of water. Centimeter of water.
So the number the accepted number is 8
to 10
centimeter of water as the gradient.
Yes.
And how many millimeter of mercury is that?
Can I calculate that?
It's 1.4 times. So 1 millimeter of mercury is 1.4 times centimeter of water, because the specific gravity of mercury is 14 or 13.6 times that of water.
13.6.
Right? And then 10.
I wanted to make it easy.
10 millimeters is 1 centimeter.
13.6. So probably around 5. All right. So, Gurmeen, if you don't mind, you have Daniel Cavalcanti is kind of trying to get back to a case. So maybe we'll have
Sure.
Daniel go next, and then you go back with the MMA.
Yeah, sure.
But thank you again. It's a very interesting topic, and
Thank you.
a lot of interest on our part.
Let's stop.
Yeah. Okay, great. Thank you. Daniel.
Yeah.
All right. Thank you. You're on.
Okay. Okay, it's a very informal presentation here. It's more a collection of cases. So first of all, I want to thank you the opportunity to be a fellow here at LMIO. It was an excellent moment of my life, excellent training. I'm very excited about every kind of skill I achieved here. So before coming here, I could practice open vascular neurosurgery in Rio for 7 years. So there's a lot of influence there. So, and then I decided to practice endovascular. So I came back to US to do a 2-year fellowship, one in Phoenix and one here. But I was a research fellow of Dr. Spassler back in a day. So he put a lot of input in my career. So everything I did in open vascular was guided by him, by his training. So then I could do this 2 years of fellowship that really changed my career. And right now I face a difficult decision on how to treat some of the more frequent aneurysms. Should I go to microsurgery for some of them, which I have a lot of experience, or should I choose endovascular for some of them? So I'm going to show some cases I did in Rio from 2013 to 2018. So the next 3 cases, of course, they are flow diversion cases in most of places that have flow diverters available. But during the Olympic times in Rio, our institute ran off of money because of all money was driven to the games. So public hospitals couldn't have more flow diversion. So these cases were coming to myself. So this 56-year-old female had blurry vision and this giant cavernous segment aneurysm. So we can see in this picture, the size of the aneurysm, the location. So I decided to do a 2-stage occlusion of the right ICA and a low flow bypass in order to treat that aneurysm. So here I'm exposing the neck and performing a partial occlusion of the right cervical ICA. And then I proceed to the low flow bypass to STA MCA. So guided by Doppler, I find the trunk of the STA, and we can see in the bottom the trunk, and I coagulate the parietal branch to give more flow to the frontal branch. So I'm dissecting that branch, and now I'm opening the temporal muscle and exposing the bone. And I can finally do my small craniotomy in order to perform the bypass. So exposing now the Sylvian fissure, and I will prep now the donor vessel, cleaning that adventitia, irrigating with heparinase saline, and now I expose my M4 branch. So here we see the superior temporal gyrus, and we see this M4 branch, and I do a temporal clipping, I open the recipient vessel, I prep even better the donor vessel, and I start the suture. So using 10-0 sutures, I complete this STA MCA bypass in order to, over time, give back all the flow that will be lost by occluding the ICA. So it was our school in Rio to not occlude completely the carotid artery in the neck in the first stage, but do it in 2 steps. 2 open steps, or 1 open and then 1 endo occlusion sacrifice of the carotid. So opening now the clips, I see flow, hemostasis was achieved, ICG was done, and show the patency of the bypass. Microdoppler is used again, and then I see good flow. So I can see here in the neck a near total occlusion of the right ICA. So I don't do it immediately in the first step. We do it in 2 steps. And then we can see some flow already in the bypass, not ideal, but I still have some flow coming from the ICA. And then the endovascular guys did a full occlusion of the carotid in a second stage, a month later. And then this is a follow-up angio showing the increasing size of the SGA. We can see here how it's much bigger now, so giving too much more flow to the MCA. And we see here in a 2-year follow-up, a stump in the ICA, and we see all of the flow in the MCA and back into the ICA. This patient particularly had an aneurysm formation in the suture line, and in the end, I want to ask you guys, what would you do to treat this aneurysm? I just follow, and then I left real, so I couldn't follow this patient any further. But some people are very aggressive treating these aneurysms because they can enlarge easily. We can see here the amount of flow, and we can see here that usually SGMCA is called a low flow, but it can really increase in size a lot and supply a big area of the MCA territory and even back into the ACA sometimes. And then when we do the left ICA injection, we see very good filling from the other side and assisting all the supply to the right MCA territory. Another patient, 64-year-old female, blurry vision, diplopia, and third nerve palsy. There is a big impact in the nerves in the cavernous sinus, and we see a petrous cavernous giant aneurysm. In this case, I decided to do a high flow bypass. We can see the skin incision, small curvilinear skin incision, and then a cervical incision in order to complete the bypass proximally in the ICA. We did ourselves the harvest of the radial graft. So my PGY5s would be doing the harvesting of this graft while I was opening the head and neck. So we can see here in this picture, I'm here with a PGY3 opening the head and neck, and 2 PGY5s were harvesting the radial artery. So we can see here real quick the dissection of the radial. It's a big incision, but we make sure to close it nicely in the end with plastic surgery sutures. And we see here the craniotomy, a chest tube to bring the radial graft from the neck up to the head. Now I prepared the adventitia perfectly, clean with heparinized saline, prepare the borders. That's the most important part, to clean the adventitia. Now using microdoppler, I prep the neck. I do again subtutal occlusion of the right ICA in the neck, and I close the ECA branches and the ECA itself. For my surprise, when I open the proximal ICA, I find a very big plaque underestimated in the angiogram, so I need to complete very quickly an atherectomy in order to go on with the bypass. So we do it, we clean, there are no plaques, it's very flush there, and then we can start suturing with 7 all-proline suture proximally. So 8 interrupter sutures are placed. That's the nice part of the bypass. It's less complicated than in the head, of course. The vessels are larger, the sutures are quite bigger. And then we complete the proximal part of the bypass, and we can see it's fully open. I'm going to skip the intracranial portion, but I can show the immediate postoperative angio, again, subtutal occlusion of the right ICA. We can see the radial artery here with an amazing flow up. And again, here in the head, a very nice flow from the radial to the whole right MCA. The aneurysm is still there, but it's going to thrombose over time. With 10 months, I came back in 3 months. I occluded completely the ICA, and now you see the size of the radial graft supplying the whole hemisphere. There's no too much flow back. And this patient did very well, and her vision actually improved. This is a 14-year-old boy with a massive, giant aneurysm in the petrous cavernous transition, measuring 6.5 centimeter in the maximal diameter. Same surgery, same kind of graft, high flow bypass. Again, we didn't have flow diverters device at this time. This was the Olympic year, 2016. So basically the same kind of surgery. I'm going to skip this step. I want to show you the result. Again, occlusion was performed in 2 stages. First stage was that day, and the radial graft is open. We see flow there upstairs. The aneurysm is much smaller now in the very initial moment. And then, interestingly, and this guy didn't pass the balloon occlusion test. He didn't pass the BTO. So we can see here over time how the graft is still open, but with just freak flow. And there is, again, a tiny aneurysm formation here. But he got a lot of supply from the contralateral ICA through the ACON and back from the VERTS PCA through the PCON. And we see in the late follow-up MRI how this aneurysm decreased so much in size, and he got very good outcome with the vision and eye movement. So the next aneurysms are really the ones that I'm really in doubt how to treat. I had such a good experience with MCA aneurysms doing a mini craniotomy that engaging in any complex endovascular treatment for this aneurysm doesn't make sense to me, at least. So we do a very tiny craniotomy. That's an example, 56-year-old female, right MCA aneurysm, multiple risk factors, and she has multiple aneurysms, actually. She has a right pike as well. So we see here right MCA bifurcation, not difficult for clipping, and a tiny skin incision, not too much shaving of the head. We see here the size of the craniotomy. I call this mini sphenoidal craniotomy. It's a little different from the mini theranal. And again, this is the size of the dural opening, 1.5 centimeter only. So opening the sylvian fissure and splitting the sylvian fissure. Here is the inferior frontal gyrus. Here's the superior temporal gyrus. Just locate people, that's the right side. So splitting the sylvian fissure, and we use no retractors anytime in this kind of surgery. So we don't impact the brain, we don't cause contusions, there's no bleeding most of times in this kind of aneurysm. So we try to go less invasive as possible. So there's no sense, at least for me, for this sort of aneurysm to do a very large craniotomy with fixed retraction and damaging the brain if you have the endovascular option. So now I expose the aneurysm completely. I see the other division inferiorly, so I apply the clipping. And the aneurysm is now clipped. So this is the cranioplasty. That's how she did immediately. And pre-op imaging, we see the aneurysm here in oblique. And in the postoperative period, we can see complete occlusion. And we would do angiograms for every single aneurysm that we clipped. 6, 7-year-old male, headaches, having a large aneurysm and seizures, large aneurysm of the left MCA bifurcation. In this case, we did the same craniotomy again, not too much shaving, small incision, small craniotomy. And I decided to resect this aneurysm actually. It was like 2 centimeter aneurysm because it easy a lot my clipping. And we see here the result. There was a little bit of double opacity here, questioning some small, tiny residual in the neck, but at least in this other image, I don't see any residual. We follow him over time, and there was no increase in that tiny image seen there. He did super well, and that's what I want to say. Not every surgery will cause swelling, not every surgery will cause atrophy. If you do it in a nice way, a year later, after, you don't barely see the skin incision or atrophy. So bilateral MCA bifurcation, bilateral MCA aneurysms. The right one is pre-bifurcation. The left one is at the bifurcation. So I will treat both with a single craniotomy, small craniotomy in the left side. So I believe this is a good benefit of open surgery in order to prevent contralateral stent coiling or contralateral or bilateral flow diversion for this kind of aneurysm. So I open here the Sylvian fissure carefully. I expose the right optic nerve. That's the right that's the left ICA, left optic nerve, right optic nerve. So I'm crossing midline now. This is the contralateral carotid in the right, contralateral MCA, and contralateral MCA bifurcation. So inferior division, superior division, and here is the aneurysm. That's the contralateral aneurysm. So I apply the clip. We check using ICG, and now I turn my attention to the ipsilateral side. And this is the other aneurysm. Checking, of course, every origin of both divisions, clearing the neck, and then we apply a clip only. No retractions for both sides. And checking patency of branches with ICG and visually. Cranioplasty, and she did very well. That's the first postoperative moment, and she can go home the next morning. So preoperative, and we see post and pre and post. For ICA terminals aneurysms, again, I still think microsurgery can be a good option. Of course, we have very good endovascular options, but for this patient, I decided to do a craniotomy in the left to treat this big aneurysm in the ICA terminus. And I could go contralaterally to treat this one close to the ICA bifurcation. Actually, it's a proximal A1 aneurysm. She still had this other one, but was too far for me. I couldn't really clip that safely. So that's the skin incision again. Craniotomy, durotomy, and then opening the Sylvian fissure, following the same steps, opening the carotid cistern, prechiasmatic cistern. I see here the optic chiasm, and coming back to the ICA terminus, we see the ICA bifurcation. ICA here, very small ICA, MCA, and this is the neck of the aneurysm. That's the neck of the aneurysm. So I need to locate the A1. Once I locate the A1, and I apply a temporary clip and 2 straight clips, and I change those 2 straight clips for a curved clip that gave me a better occlusion. So now I remove my temporary clip. I never leave a temporary clip for more than 2 minutes. And then we use the ICG to check. I go to the contralateral side. I see the contralateral optic nerve. I follow the A1, and the A1 will take me to the other aneurysm. So this is the contralateral A1, and I see here the distal neck, and here the proximal neck. Proximal neck, distal neck. So now I apply a fenestrated clip to treat the contralateral aneurysm. So we could treat both of aneurysms in the same setting. And I really wanted to clip this one as well, but it was not safe, and I saw a branch coming off the dome of the aneurysm. That's, again, bilateral aneurysms. That's an interesting one, treated with only one craniotomy. So a choroidal one in the right and ophthalmic one in the left. So a little larger craniotomy that was previous in my career. So opening the Sylvian fissure, carefully, no retraction is used. And I open the carotid cistern in the right. I clear the optic nerve in the right. And I try now to go to the contralateral side. I'm crossing midline now. And this is the contralateral optic nerve. Here, you guys can see the contralateral optic nerve. That's the right optic nerve and left optic nerve. So I start to raise carefully the optic nerve in the other side. and then that's the carotid. So I start to see the neck of the left ophthalmic aneurysm. That's the proximal neck, distal neck, and I want to see the ophthalmic before I clip. So I put the clip in the ophthalmic aneurysm, and then I protect the ophthalmic artery. Now I turn my attention to the ipsilateral aneurysm, that's the choroidal one, and I cleared completely the neck of the aneurysm, and I see the choroidal there, I see the choroidal in the back. I apply gently this straight clip, and everything went very well. Choroidal is protected. There's a little residual. I coagulate here. It's safe now, and I can proceed. So pre-op, choroidal, post-op, choroidal. The choroidal is open. Pre-op of ophthalmic aneurysm, it's open, and we see the ophthalmic here. He's doing very well 6 months later. So now to conclude, SCA aneurysm. So that's an aneurysm that's coming from the very proximal SCA and not really from the basilar. And we do the same kind of procedure, a small craniotomy here, a little bit larger because it's a more distal aneurysm. And I was kind of unsure to do with a tiny craniotomy, so we enlarged it, but still not a large pteryginal approach. She was 41, and dissecting the Sylvian fissure, opening, we can see signs of bleeding. So she had all the symptoms of bleeding 1 year before. So of course she bled, and she was not adequately screened for subarachnoid hemorrhage and aneurysm. I'm going through the carotid oculomotor triangle, and I get to the interpeduncular cistern here. So we see the basilar tip here, contralateral PCA, ipsilateral PCA, and this is the neck of the aneurysm. That's the neck of the aneurysm. That's the basilar artery here. This is the carotid. This is the basilar in the back. Third nerve. So I apply the clip in the SCA. That's the basilar tip. That's the contralateral SCA. So ICG helps me here seeing complete occlusion of the aneurysm. So that's angiopre and CTA pose showing complete occlusion of the aneurysm. And here's she before she leaves. A pica aneurysm, again, that's a pica aneurysm originating from the pica itself, not from the basilar. That's the kind of aneurysm that sometimes flow diversion doesn't bring complete occlusion immediately. Sometimes you need a second device, sometimes it never goes away. So I still believe a small craniotomy to treat this aneurysm can be a very nice approach for this aneurysm. Again, it's not a huge lateral approach. It's not too much dissection. We want to do a tiny hair trimming, tiny craniotomy, and I'm going to clip this with a small retrosigmoid craniotomy. So trying to be less invasive as possible. So I dissect the lower third of the CP angle. I show the pica, and we see the lower cranial nerves entering the jugular foramen. We can see the accessory nerve here. The pica is here, so the hypoglossal nerve sitting on top of the V4 segment, and we see that that's a calcified aneurysm. I see here the pica itself. So my goal now is to dissect free the aneurysm. And you see, we never use, for these cases, retraction. So I go less invasive as I can. Don't touch anything else. So I can see the distal neck of the aneurysm and the proximal neck. And I apply this clip, protecting the hypoglossal roots. And finally, getting a good result, protecting the pica. We can see the pica here. I really wanted to bring this clip closer to the neck, but it was closing the pica with the ICG. So that's where we left. She did well in the postoperative period. We can see, and all these pictures were given with consent of patient. They are in a paper that we wrote. We don't see too much shaving here, and we see a complete occlusion of the aneurysm bringing patency to the pica. And that's my last case real quick. That's probably a classic case for pipeline nowadays, no doubt. But patient has a kind of fusiform dissecting aneurysm of the distal V4 segment, very adjacent to the orange of the pica. Again, if we go very low invasive with not too much dissection, I still think that microsurgery can give a very good result as it gave in this case. So same kind of procedure, small craniotomy, small heterocyte craniotomy, not a large far lateral approach. So people cannot talk about a lot of invasion here. Opening the low third of the CP angle, I can show all the lower cranial nerves here, and we protect them carefully. So my goal here to expose the V4 segment. I'm going to the end of the case. We start to see the aneurysm in the back. This is the accessory nerve. We are on the right side. This is the hypoglossal branches. We see here the aneurysm. So I protect the aneurysm. I dissect it free from the hypoglossal roots. We don't touch the nerves too much. I see the distal V4 there. So distal V4. So I have proximal and I have distal control. I'm clipping here. Clipping. I do the ICG. The video is so slow, I'm sorry about that. We see the ITG, V4 segments open. So 2 clips are necessary to really close this aneurysm completely. And this is the final picture. So pre and post, looks like there is a flow diverter there, but there's not, there are 2 clips. And then here, pre and post, a tiny, tiny stenosis here. And this is the final case, and thank you very much again. I'm open to questions. I want to thank again Dr. Nelson, Dr. Shapiro, Raz, and all the other attendings areas for my excellent training this year. And I'm going to apply endovascular neurosurgery and interventional radiologies in my daily basis. Thank you so much.
Daniel, thank you.
I'm sorry to show so many surgical cases. I just felt that after all these banana meetings, I couldn't show anything on endovascular that would be very interesting for you guys. I had to show some open cases. Thank you.
No, it's obviously it's a very large, excellent collection. Any comments from anyone? Questions?
Yeah, okay, it's Kiripong here from Japan. Very nice presentation, Daniel. Excellent. I've never imagined anybody clipping bilateral MCA aneurysms by single craniotomy. I started out as a neurosurgeon myself, and the last clip I did was like 2 or 3 years ago, and I don't want to be like good at both, you know, doing both craniotomy and surgery and also endovascular. I would like to focus my work on more on the endovascular side. But anyways, I've heard that the neurosurgery people in Brazil is extremely, you know, strong concerning what they can do in their surgeries. So, you know, to compete with the very strong neurosurgical community, we need to have, you know, we don't just put 2 very loose two coils inside a, you know, 5-6 millimeters aneurysm. That will not be able to compete with very good surgery. And but I don't know, your surgical field was so nice, you know, the retraction was so minimal and everything. And sometimes I even imagine people putting like 2 stents to treat an MC aneurysm, which can be clipped very easily. And you only need 1 craniotomy to treat 2 MC aneurysms. That's that's just like the opposite of that and very fabulous. But for training, we have been having problems with training for the trainees to how to teach them to clip aneurysms, because we don't do a lot of clippings anymore. Even in Japan, it's like in Europe probably almost 100% they do endovascular for aneurysms. But for in Japan, probably like 70%, 60-70% we do endovascular, and the rest we still like clip aneurysms. So the percentage of clipping of the aneurysm is decreasing. So what do you think the future perspective? You're doing a very excellent job, but will this last for another like 20, 30 years? I don't know. It was so excellent that I'm not sure many people can really imitate what you have shown. It's not really a question.
Yeah, so the main reason here for the last 2 years is really because in private practice in Brazil, there were no aneurysms anymore to be treated. All the cases went to endovascular. And I was doing all these cases in the public system in our institute, actually. So there was a major split. So, and I didn't want to lose those cases. I want to do those cases with new technology, with endovascular. So, but the conservative guys would tell me all the time, oh, you shouldn't treat endovascularly. You should stay on microsurgery, but that was not my goal. I want to do what is appropriate, and that's why I came here. Yeah, I had a lot of ophthalmic aneurysms to show, but it would be so long. But I don't see people clipping ophthalmic aneurysms anymore, and I just don't see people clipping and doing bypasses for all these giant aneurysms anymore. Our results here are so good. We did recently like some pipelines for ACON aneurysms with great results, H constructs. So it's very hard really to convince patients and your group and your neurologists that clipping, you're doing a better job. So, and we just don't have the cases to train our new residents. So it's very unlikely that they will have this kind of training in the future.
Yeah,
then you need volume, and you can clip very well an MCA, and then you don't have any skills with basilar, any skills with SCAs, any skills with ACONs. So it takes so much time to clip all those in a nice way. Yeah, I think it's a lost art as well.
Yeah. Okay. Thank you.
Thank you. There's a lot of. I don't think we have time enough to like really consider all the aspects of this continued, landscape of how this evolves, different places, different techniques across the world. And it's clear that I think in general, as Kitty Pong is mentioning, the endovascular proportion is on the rise. You're one of the exceptions to having been exposed to like excellent endovascular, hopefully, and open training as well. But I think it's becoming increasingly rare. And I guess if there was only, Kitty Pong also raises a question that Kim Nelson, I don't know if Kim is here. Kim, are you here? I think he has a case actually. So it's always a question of like, can you be excellent at both? Like, what does it take to really be a master of this, that, or the other? And to me, particularly, the question has always been, based on what I've seen, Daniel, in the sort of the results that I've seen from across the spectrum of clipping, I wonder personally what it takes, like what is the cost of training an excellent open vascular surgeon in terms of like, what is the volume? What are the complications that have to be incurred, particularly with like high-end stuff that you do to continue the tradition? Does that, and what is the human cost of that? And depending on what you do, it's probably like not very small. So I don't know. I wonder someday probably endovascular will be supplanted by something else. Maybe there'll be medical therapy or something, but there's an evolution to the field, right? Like there are lots of surgeries that used to be necessary that we no longer do as a field because there's just you know, that's just how medicine evolves. So I don't know if that seems like how things are going. I'm certainly very, you know, differential to your experience and the ability to do what you do, because as you mentioned, you know, I hope there are more flow diverters in Brazil now than
Yes.
at that time. But there are places where that's really still not possible.
Right.
Um,
Yeah, it's interesting. When I had the chance to give 3 talks in Peru in the beginning of my fellowship. So when I really felt that things were hard in the public system in Rio, and I could see how they're doing there, they barely have some stuff, some basic stuff. So, I mean, I'm sure there are a lot of places where it's still needed, the skills are still needed, but still they're so hard to achieve. Years and years of practice, maybe human cost has, how you said, maybe can be too high in this particular era where endovascular is standard. So yeah, I just see myself really clipping MCA aneurysms, but anything else, really, it's hard to compete.
Daniel, thank you very
Thank you so much.
presentation. Anybody else? Questions, comments?
I really want to understand if somebody has experience with that aneurysm formation in the bypass line.
Okay.
What you do there?
What do you mean, aneurysm
Yeah, there was
formation at the site of the bypass?
Yes. Yes.
Yeah, we had a few recently.
It's like 10 years ago that the patient had bypass, and she developed this very small, she had a bleed around the area of the craniotomy, so we did an angiogram. I don't have the pictures right now. There was a very small aneurysm, not at the site of the suture, but at a very small branch of the STA. That was, it's more like not the direct bypass. It was the result of the indirect bypass formed maybe years after the thing. And it has this really micro, very small aneurysm that just popped and caused the bleeding. That was our recent case probably 2 years ago. Not very often that we see that. Why did you ask the question? Why did you raise the question?
Yeah, because I showed that first case with fusiform aneurysmal dilation there, and I was really concerned on treating that. So looks like they are very fragile and they enlarge fast, but it didn't enlarge in 2 years. So I decided to follow it.
It's very rare, I think.
Okay, thank you.
Right. Okay, thank you.
Can I ask a question?
Yes, please, go ahead.
Hello, I'm Rafael. I'm a resident from Brazil, from Rio. Thank you, all of you, for organizing this webinar. It's very interesting for us. And thank you, Daniel, for all those wonderful cases. Watching surgical cases is always interesting for neurosurgery residents. I wanted to ask you, Daniel, and all of you who have more experience, I have seen some cases of surgery that was performed on failed endovascular. After a few years, the aneurysm would come back bigger, would become a giant aneurysm, and then people would proceed to do surgery in these cases. Do you all think that maybe in the future, surgery will be reserved for these cases, or maybe these cases won't be even existing anymore with the improvement of endovascular technology? What's your view on these, specifically those failed endovascular cases after years, which are, I think, are going to be more rare as time goes by?
Do you want to answer that, Max?
Yeah, of course.
Yeah, during the fellowship this year, we had several cases of coiling from the past years ago. We treated one this week that was coil in Mexico 2 years ago, and then we piped. We got a very nice initial result. So yeah, as time evolves, we will see some coil cases in the past that will be nicely treated with flow diversion and other new technologies. Clipping can be an option, but still going less invasive should be the first way to go at my point of view.
Yeah, I think by now, I think there's a decent body of literature on basically like, it says mostly flow diversion. What's interesting is not adding more coils to a recurrent coil. It's more about like a different way, and a lot of the literature is on flow diversion, and I think that's most of it. Obviously, I mean, it's favorable. There's probably some biases involved in that. Our experience is mostly endovascular, a different endovascular tool to address an endovascular problem, which is mostly like a coil recurrence. Right. Again, thank you, everyone. I think the chat, no questions in the chat. Fermin, are you here? Do you want to continue? If you can hear us.
Do you want to give others a chance? I'm kind of running short on time. If there's time, I'm still here.
Yeah. Anji, go ahead. Let me, if you could, yeah, you got control.
Okay.
We have just about 15 minutes left, so probably we can have like a 10-minute presentation or so.
Mine should be shorter than that. So I'm just going to talk about this paper that, we've been doing this. We've done this for about 17, 18 patients, and this is submitted for publication, currently under review. So what we've been doing is using very dilute glue for MMA embolization. So, I mean, in the recent years, MMA embolization has begun to be used for refractory or recurrent chronic subdural hematomas. And the concept is that there's a formation of neomembrane with the MMA branches providing feeding vessels to that outer membrane connected to the dura. And a lot of centers have used particles as well as onyx. And I know there's ongoing trials being started for both particles and onyx. What we tried was using very diluted glue. So 1:6 dilution of glue and iodized oil. And we enrolled a total of 16 patients. The primary outcome was safety and technical feasibility. The secondary endpoint was reduction in hematoma volume. And concomitant burr holes were performed in 12 of those 16 patients. So what we basically did was used very dilute glue using a Prowler Select Plus, but on the guide catheter, we used two 60 cc syringes of D5. And while one operator injected the very dilute glue, the second operator injected D5 to promote distal penetration of the very dilute glue. And most of the times with just a single, basically we saw a glue in one of the branches, whether it was frontal or parietal, and then we saw reflux of the glue into the other branch, and we managed to occlude the MMA pretty distally within seconds. Here's a couple of videos. Here's another one. So we're in one branch, we pull the microcatheter back, and then there's reflux into the other branch. This one more time. So the primary endpoint, which was safety and feasibility, was met in 100% of our patients. The 7-day CT showed 50% reduction in subdural volume. And we also did a 21-day and 3 months. Some of the results we're still collecting. Here's a couple of examples. This is a patient, as you can see, there's both acute and chronic on the right, and then there's bilateral subdurals, and this is the MMA. This is the C shows the glue in the branches of the MMA. The D is a follow-up single shot showing the glue lining up the MMA, and these are follow-up imaging showing resolution or significant decrease in the size of the subdurals. Another example where you can progressively see the decrease. This is a 7-day, 21-day, and a 3-month follow-up scan. That's all I have. Happy to take questions.
Thank you. Thank you. Okay. Any questions?
Has anybody seen transient increase of the subdural after embolization?
We haven't, and that was actually one of our worries because we were pushing with D5. That is why we were doing short-term follow-up scans, but we did not see any increases, no.
Mm-hmm. Yeah, I had one case that was a significant subdural, and I did particular embolization, and it became, you know, he was having headaches to begin with, and he became, you know, more headachy, no neurologic symptoms other than that really, and I repeated a scan a week out, and the thing was noticeably thicker. And so eventually at 1 month, because of the incessant headache, the neurosurgeon, who happens to be John Engler, who trained at NYU, he ended up doing a small burr hole, and then you know, that was the end of the story. But it made me think, and I made a few calls at the time to see what people are thinking about it. I spoke with a couple of people who have done a larger number of cases, and so one of the ideas was that maybe the contrast that gets injected is a osmotic agent, and that may cause it, although I don't see how it can last that long. And so I was thinking maybe I was overdoing the embolization with the particles for a larger than necessary volume. It's an interesting problem. But in the people I spoke with who have had a number of cases, there were a couple that had said that it had occurred to them on the occasion. It's very rare, but it has happened.
We've also had a couple of cases that, as you mentioned, the minority, most of them get better. A few did get worse. Eitan has a question. What's the purpose of day 1 to 6 for glue? Gurmeet, I don't know if you can hear.
Actually, even Dr. Al-Mufti, who's my mentor, and this is online, I don't know if he wants to add to this, but distal penetration, and it like with the D5 solution, it leads to very good distal penetration.
But when you say diluting, you mean diluted with lipiodol, right?
Yes.
So it means that it has higher concentration of lipiodol compared to MBCA.
Yes.
Regardless of the D5.
Yes, regardless of the D5, yes. It leads to better distal penetration.
It doesn't memorize as quickly. Even though
hey guys, so I just joined. This is Fawaz Al-Mufti. So I'm assuming, sorry, I'm joining the party late. Yeah, so to Gurmeet's point, so when you, the trick to all of this is getting this penetration to the neomembrane, or the neomembrane that forms around the subdural. And with the pathophysiology resistance in any of these tiny vessels, like distal MMA, it's actually backwards. So if you're injecting like 1-to-1 or like 2-to-1 dilution, it's going to want to reflex back on you. That's basically the problem. The more dilute it is, the more likely it is to penetrate forward. And we've also been doing, in addition to this, I don't know if you guys spoke about this, but we've been doing like a D5 push in addition to facilitate distal penetration. It's like give the patient a sugar rush to make sure that you get as distal penetration as possible. We've trialed different dilutions at this point. In my practice, I've noticed that this is probably the best. And all you need to do is get into the posterior branch and as distal as you can, and then ultimately it refluxes through collaterals. It goes anterior, like it goes downstream, and then refluxes back through collaterals, and essentially includes everything. We are in the habit of always doing like a CT post-op, like on the table. It's actually pretty impressive how much penetration you get intracranially using the NVCA.
So
I have a question. Yeah, go ahead.
Go ahead.
Yeah. So this is Tibor Besky. So being a particle guy, a strong believer in distal embolization coming from many angiomas and stuff like that. I started off thinking, okay, so the way to do this must be that you have to really permeate things to the level of the membrane to be effective, right? Because I thought if you just cut off the proximal branches, then it will reconstitute and it will be of no use. But then I had that one complication where the patient got more symptomatic from swelling, and that made me a little bit rethink. And the question is, is it more like an epistaxis where you just need to cut off the proximal, the pressure head on the thing, and that is sufficient? I don't have an answer. I'm just asking on what basis do you believe, or do we believe that we really need to have distal permeation?
Yeah, I think that's a fantastic question. So one thing I've noticed is, we got a lot of referrals from like other hospitals. And one thing that we've noticed in some cases where the patient's actually undergone a craniectomy with complete evacuation of the subdural, sometimes they will ligate the proximal MMA. One thing that I've noticed is some of these patients, they've actually reaccumulated. So when, and they were referred to me, or I was consulted for embolization at that point. What ends up happening is when I do the run, sometimes like the posterior branch is still on, like it's still filling. Like they occluded the MMA just distal to just distal to its intradural component, or they bust it, or I'm not sure what. But then you find all you need is one collateral, one posterior branch, and somehow everything else is actually collateralizing through that one branch. And then when you do the run, when you actually get into that branch and you do a super selective run, you actually find these tiny collateral branches supplying this new membrane. So I do think, and like, again, at this point, we've done, I would say in total, probably like 40, 50 cases, like in our group, like where our experience is still probably in its infancy. But I would say in these handful of cases where we've seen recurrence after ligation or cauterization of the middle meningeal artery, if there is a tiny branch that is still like filling for whatever reason, then you do see recurrence in these cases. So I personally strongly believe in distal penetration for that, and that is essentially my proof that I think it's definitely important.
Makes sense.
We probably have to move on in the interest of time, but it is an interesting, obviously very emerging topic. I had one last question in terms of, so I think I understand your technique. You're not using like a like if you help assist penetration, you go into one branch and you let reflex into the other. Any concern over anastomosis with other systems, ophthalmic, facial nerves? I noticed some of the glue has come down pretty proximal. That is a concern. So
yeah, no, I think that's definitely a concern. We do this very, very carefully. For the most part, what I've noticed is first of all, if there are collaterals with the ophthalmic, usually you do see some communication. For the most part, going as distal as possible. What I've noticed is you actually get this penetration to the neuromembrane way before you get penetration into the normal branches. And I haven't really had any, knock on wood, I haven't really had any complications at this point. I'm sure I will at some point. But up until now, I would say just studying the anatomy very well, making sure that there's nothing that you're, if you think about it, if your contrast, your initial superselective run doesn't necessarily, if you wait long enough, it doesn't pacify any of these dangerous collaterals, and you're that far distal, it's very unlikely for that to reflux all the way down to the ophthalmic without you paying attention. I think it's important to reset your roadmap multiple times to make sure that you're not missing anything. But yeah, no, I think it's a valid point. We just haven't seen it yet.
Okay, and then Nathan Farkas asked the question on the Zoom chat. If you can see that. Question is about collective experience. Is there any rate of effectiveness or technical success of embolization in terms of the percentage of MMA territory covered? I guess that goes to follow up on the question of how much do you have to really do in terms of the territory proximal penetration, that along those lines. I don't think that's been studied, right? That anybody.
Yeah, I don't think it's been studied. What we've typically been doing is I try to penetrate the distal third of the MMA and I get as much of the neomembrane as possible, as close to the subdural as possible.
There's also a lot of variation, as you mentioned. The more you look, the more you see. When you see people, when you do an angiogram post-craniotomy, very often you see posterior or anterior meningeal arteries reconstituting the MMA because the MMA has been surgically sacrificed. So obviously that's going to happen. The question is, is a high-end subdural embolization through a posterior meningeal, does that have any validity or not? Probably would be interesting to see.
Yeah, I agree.
All right, Gurmeen, then thank you, everybody. Thanks for presenting. We have a couple more presentations, so we'll keep moving. Let's see. Keisuke, can you hear us?
Here.
Great. Okay. So we are at, let's go ahead. Let's keep going. I think we have two more. So go ahead.
Can you see the slides?
Not yet.
Not yet.
Yeah, okay, good.
Can you see the slide?
Yes,
okay.
yes.
I will present about the branching patterns of the pterygovaginal artery. I'm Keisuke Yoshida, Keio University School of Medicine from Tokyo. I went to a banana course in 2019 at NYU, and it was a very fascinating experience. And there, Dr. Ethan Rutz introduced me interesting artery and about this article, the palatovaginal canal. So the palatovaginal canal can be identified on coronal CT by locating it to the inframedial to the Vidian canal. This is palatovaginal canal, and this is Vidian canal. And recurrent branches from the distal imax, I think 4 arteries exist. And pterygovaginal artery have another name of pathophysiological artery and pharyngeal artery. And pterygopalatine fossa is a narrow space surrounded by sphenoid bone, maxillary bone, and palatine bone. And there exist 3 canals from the posterior wall of pterygopalatine fossa. And pterygovaginal canal is here. Inferomedial, it has an inferomedial course. And pterygovaginal artery is usually small artery, but can be enlarged when supplying hypervascular lesions, and can be hard to distinguish in conventional angiography, but can be evaluated with cone beam CT or dyno-CT. And it rarely becomes a target of embolization, but numbers might be increased, I think, due to the spread of endonasal endoscopic surgery with narrow surgical space and limited instrumental maneuverability for hemostasis. So like in CT, using cone beam CT, we can identify pterygovaginal canal. So this is number 7 is Vidian canal, and medial to it, there exists pterygovaginal canal. In coronal, this 9 is pterygovaginal canal. I present 2 cases of selective embolization of pterygovaginal artery. This is a 66-year-old woman with a history of von Hippel-Lindau disease and multiple surgeries for intracranial hemangioblastomas. So preoperative embolization before a resection via endoscopic endonasal surgery was performed. There was a feeder from the distal IMA, internal maxillary artery, and it was, they were left sphenopalatine artery and left pterygovaginal artery. Also, left posterior ethmoidal artery from the ophthalmic artery was feeding the tumor. So this is the microinjection from the pterygovaginal artery, and we can see the pterygovaginal artery is branching from the distal IMA, relatively distal portion of the IMA. This is pterygovaginal artery, and microinjections shows tumor stain and nasopharyngeal blush. And this is case 2. This is also considered hypervascular lesion, which involves sphenoid sinus and anterocranial base and clivus. This was a 20-year-old man with right abducens nerve palsy. And the lesion was applied by external carotid and also from internal carotid artery. So I will show the microinjection from the pterygovaginal artery. And I thought this angiogram was interesting, showing several anastomosis. This is pharyngeal branch of ascending pharyngeal artery. And this lateral view shows also pharyngeal branch of ascending pharyngeal artery. Also, you can see here, this is ascending palatine artery from the facial artery. So the microinjection showed tumor stain and nasopharyngeal brush, and also anastomosis with ascending pharyngeal and ascending palatine artery. So I draw an illustration to understand that the course and anastomosis of vaginal artery. It might be not anatomically correct, but this is an illustration. And I think two important anastomoses exist. The one is the anastomosis around the Eustachian tube, and the other is the anastomosis around soft palate. And the pterygovaginal artery can sometimes supply not only nasopharyngeal lesion, but also paracellular lesion, like cavernous sinus dural AVF. So in the case 2, we embolized with embosphere while we advanced the microcatheter close enough to the lesion, and after that we pushed retracted back the microcatheter and inserted coils to stop the feeding. So I found it interesting in these two cases for the branching pattern. In case 1, we can see by axial cone beam CT, this is an distal internal maxillary artery, and it branched from distal part of the IMAX. And in case 2, when we see axial view, it branched from relatively proximal portion of distal IMA. And I think this narrow space is pterygopalatine fossa, and pterygopalatine fossa connects to the infratemporal fossa with the pterygomaxillary fissure between them. And in case 2, the artery branched from the infratemporal fossa. In coronal, you can see the branching like this. And here, yeah, relatively distal lateral branching pattern. So I draw illustration, and this is the course of IMAX, and there exist 2 courses, I think, for pterygovaginal artery. The one is medial origin, and the other is lateral origin. And the lateral origin course of pterygovaginal artery courses posteriorly to the nerve structures. This is written in the article written by otolaryngologist study of 20 cadaveric specimens. So they conducted the study to depict the course of distal IMAX branches, and they said there exists medial origin and lateral origin, and lateral origin is rare, and among 25% of the pterygovaginal artery arose from the infratemporal fossa lateral to the pterygomaxillary fissure. And in these lateral origins, the pterygovaginal artery goes through the posterior plane of the nerves, and the pterygopalatine ganglion is in the pterygopalatine fossa, in contrast to medially originated pterygovaginal arteries with a usual artery course anterior to the nerves. So I made consideration about embryology, and this is an famous important article about the origin of the Vidian artery. And it says the Vidian artery is originated from the internal carotid artery, and the primitive maxillomandibular artery, and the network of these vessels becomes connected to the external carotid artery, and this makes a median artery. And considering the proximity of the anatomy, I think the pterygovaginal artery is also formed by this arterial network. And so, as the pterygovaginal artery is originally derived from the internal carotid artery, there are cases where we can observe the artery from the ICA. This is median artery, and this is pterygovaginal artery. It courses inferior course of the median artery. And this is from our case, a case of maxillary AVM and a parcellar AVM. Here, the median artery and pterygovaginal artery supplies the AVM in the pterygopalatine fossa with different course. So I reviewed our preoperative embolization cases and found other cases supplied by pterygovaginal artery. So pterygovaginal artery can be a feeder of tumor when the tumor is involving cavernous sinus or paracolival lesion, or of course in the nasopharyngeal region. So we conducted evaluation of 78 tumor embolization cases and 25 size of convenient CTs covering the pterygopalatine fossa was available. And in five cases, the pterygovaginal artery were feeders of tumors. And in our cohort, the branching patterns from the IMA were medial to the pterygomaxillary fissure in 12 cases and lateral to the pterygomaxillary fissure in 8 cases. So relatively lateral origin is relatively rare, but seemed more often than previously reported. Thank you.
Thank you, Keisuke. So excellent work, and a lot of work too. Obviously went into this. Any comments? Anyone have any questions, comments about this?
Okay, I have one. Hear me? Can you hear me?
Yeah.
Okay. Well, thank you very much. Very beautiful work. A lot of people still get confused between this one and the median artery, and sometimes you see it on we don't do a lot of cranial base tumors, so we see more often, as you said, when we do cavernous sinus fistula. And concerning the medial type and the lateral type, is it because of the course of the internal max itself, the superficial course or the deep course of the internal maxillary artery? Is that one the cause of the branching pattern of the pterygovaginal artery? Did you have any idea about that? Did you find anything about that?
So as we see our cases, there is no connection to the proximal portion of the courses of the proximal portion of IMAX. It is maybe so it is not related to the proximal course. Yeah.
Okay.
I have also a comment. Thank you, Keizuke. This is great. The drawing really amazing, and this is an artery that is really forgotten very often. Now I just have a comment. You kind of touch upon it, but essentially one question that comes up sometimes, very often actually, with mostly with the neuroradiology colleagues is what goes through the foramen lacerum, right? And does anything goes through the foramen lacerum? And in terms of vessels, and one vessel actually that goes through the foramen lacerum is really this connection between the mandibulovidian coming from the ICA and the pterygovaginal artery. Okay, so the mandibulovidian would give a branch that goes through the foramen lacerum and then goes anteriorly and connects with the pterygovaginal artery, like creating sort of this like arcade between the ICA and the distal IMAX.
Thank you.
Right. It's really, I think the DINA, the whole cross-sectional imaging, the improvements that we see with angiographic technique, there's so much, there's just a wealth of information there that probably we're like severely underutilizing. As much as we're looking through each of them, there's just so much in there. For every artery, we could probably have a whole new generation of publications and research related to this, because I don't think we've seen them that well with that much frequency and the ease of use that we can see them. So I hope that takes off. Keisuke, thank you again.
Thank you so much.
Matteo, can you?
Yep.
Okay, so we are great. Can you hear?
Yeah, can you hear me?
Yes, thank you.
Okay.
Thank you for your patience. I know it's
no worries.
late, but thanks a lot.
Thank you. So. Okay, can you see it? Can you see the presentation?
Yes.
Okay, so I'll briefly introduce myself. I'm Amedeo. I've been working in Milan for the last year and a half with Daudi Boccardi, and I finished my residency 2 years ago, and then go back in Milan to work with them. I'm going to present a short case about an unusual cause of trigeminal neuralgia due to neurovascular conflict. This is the case of a 61-year-old male who had previous surgery for tetralogy of Fallot during his childhood, but we didn't know anything about it. We did not have any documentation about it. So he came to us because he had a progressively increasing trigeminal neuralgia, and it was not responding to medical therapy. So this was the MR he did at the arrival. You can see here the right intracranial vertebral artery compressing the trigeminal nerve and dislocating it on the left side. Here on this coronal reconstruction, you can see the left vertebral artery and the trigeminal nerve here. And the angio-MR, no left intracranial, well, there was seen no flow in the left vertebral artery after the pica. So we decided to do a CTA. We saw he had a right-sided aorta here and left subclavian occlusion here. The left vertebral was still patent, but most probably was reverted from the for this subclavian stele. You can see here this tiny basilar trunk and this huge intracranial left vertebral dislocated upwards and to the left. And here you can see it from behind. So this is the left vertebral artery, and here from above. So at the beginning, it was proposed to make a bypass, a carotid subclavian bypass, to solve this problem, but we thought we could make something endovascularly. So Dr. Pero Guglielmo, who treated this patient, actually, I was still a resident, I helped him. So during the angiography, we saw clearly the subclavian stele here. The tiny basilar trunk here was totally refurnished from the anterior circulation, as you can see here, through huge PCOM, bilateral PCOM. Then we saw the main collateral to the subclavian was this intercostal artery that was arising from the aortic arch. We thought it was a supreme intercostal artery going full caliber through the left subclavian artery. Here you can see the deep cervical arteries and the costocervical trunk going through collaterals, retrosomatic collaterals to the subclavian too. And here is a selective injection of an ascending pharyngeal artery. You can see here the descending branch of the neuromeningeal trunk of the ascending pharyngeal going to the vertebral artery. And here this huge muscular branch revascularizing the ascending cervical artery, going to the subclavian itself. This is a selective injection of the occipital artery, and you can see this tortuous vessel is the deep cervical artery going to the subclavian as well. So here we thought there was room to do something endovascularly. So we decided to treat it, performing prior a balloon test occlusion. So we used these materials here, and we decided to inflate the balloon here because we thought it would be the best place to occlude the vertebral artery, because there were a lot of collateral going to the cervical left vertebral artery. So we wanted to salvage as many collaterals as possible. We did the balloon test occlusion, and we had a constant pressure, systemic pressure monitoring on the left arm, and there was no modification. So we decided to, this is a balloon test occlusion. We had a 5 French on the left common femoral artery, and we performed all the controls angio from all the collaterals I showed you before, and they were not modified. So we decided to occlude it. These are coils here. And the patient was discharged completely asymptomatic with no ischemic complication to the left arm. Thank you. It was a short case. I thought it would have been better like this.
How was the trigeminal?
Yeah, I can show you. The trigeminal was
No, I mean symptomatically after the procedure.
Well, it was in 1 week, it was completely resolved. It was progressively decreasing his pain, and after 1 week, he had no more symptoms. Unfortunately, I don't have any follow-up imaging because we lost the patient at follow-up, but we're trying to get some.
Amazing, thank you.
Thank you.
Thank you, Amadeo. It's beautiful images.
Thank you. Thanks to Guillermo. Guillermo did this.
Yeah. Nice.
I was just struggling on neuroangio, trying to understand something about this anatomy at the time.
It's great stuff. I mean, it's interesting. Obviously, the vert was doing something, right? Like the reason the vert was contributing to through the vertebrobasilar, through the junction. So I wonder what the timing of this is. Obviously, he tolerated it well, like in terms of his pressure, right?
By occluding the vert, you probably force the other collaterals to do a stronger job.
There's
Right.
Like,
Yeah.
sorry, I'm not sure if I may have missed it, but how did you get to the left vert? From the arm, you went radial from the left side, probably?
To the left vert? No, we just crossed the vertebrobasilar junction from the right side.
Oh, okay. There was an image where it seemed the wire was coming
Yeah, I can show it. Just give me a
from. I
second.
mean, it's not too important. It's just,
Here.
yeah, here it seems like I see the wire. Oh, I see. Okay, yeah. So the catheter, I see. I understand. So the reason the opacified part of the wire is only the distal part. That's why.
Yeah.
Yeah. Yeah. The other option here was going from the radial on the left.
Yeah, sure.
Any other question? I mean, I don't know if we know, but like the etiology of the occlusion, it's interesting, right? The other is a
Yeah.
arch. Like,
Actually, I don't think we still know about the etiology of the occlusion of the left subclavian, because on the C, we don't know anything about what he did in his childhood. But there were some clips around what we thought it was the origin of the left subclavian. So maybe during surgery something went wrong. I don't know, but it looked like the occlusion was there for a long time.
yeah, yeah. Judging by the collaterals, and yeah, obviously like very effective collaterals.
Yeah.
Cool. Thank you.
Thank you.
Anything else? Any comments? Beautiful case. All right. I wanted to, okay, so I just want to follow up very quickly on the Vidian business, because I can't help it. I'm sorry. Just last week, a friend of ours, John Clemente, who was actually a long time, he graduated from NYU fellowship when I started my internship in 2002. He did back in the days, like he was a neuroradiology fellow, and they did like a 2-year fellowship with a lot of exposure to angiography. That's not like really the case anymore in most places, at least in the States. But he came across, he's in Charlotte now, and he came across this case here. I just want to show it very quickly, because we're talking about that with the whole embryology thing. So here is can you see the screen?
Yep.
So this is the, this is what Keisuke, you're referring to the hyostapedia stage. We were talking about this very interesting embryology of like basically like early supply of the IMAX and the MMA and primarily IMAX, MMA, and the ophthalmic system through this like hyostapedial artery, of which the Vidian artery is also like is on the spectrum of that like early connection to the external system. And so that's that's just a diagram of how that works. And then we almost never see that in adult. We see sometimes like occasionally we will see a hyostapedial supply to the MMA, but to see it to the IMAX is, I think, vanishingly rare. There's one example in a phases patient from Los Genius's book. So like, anyway, so like this other day, Jonathan is like, hey, look what I came across. You see this? Like, so here's the left side's fine. This is also a person with some cardiac issues, so might have phases, as Kitty Pong was mentioning. Like, I don't really know what the underlying syndrome is. That's important. But morphologically, so look at left side's whatever, it's fine. Right side, you don't really see, like down low, you don't see external branches. And now you start to see, like, you see this giant Vidian artery. And if you trace it back, I mean, I can't like scroll through this, but if you trace it back, that's what's really like going to supply the IMAX, both distally here and proximally. And the STA, you see like the little STA here. I don't know if you see the mouse here, like sometimes it's hard to see the mouse. Yeah. So, right, so no external branches here, giant Vidian, and here you see the IMAX distal, kind of proximal. Here's the MMA, and that is traced back to like, there's like a little tiny connection from there to the MMA and to the STA. So anyway, that's just like, again, small world. Just came across the other day. Super rare. I don't know. I don't, Kitty Pong, and if you guys, anybody wants to comment on this, I wonder, like my question about this is always, always been like, if this is really, we believe that this is the early embryo, but we see this almost never. Like I've never seen this in actual life. This is the first time. Kim has a case that was lost because of the Hurricane Sandy we had here years ago. That was cut film. So I've heard of that one, but it's so rare. I wonder if I can see it more often.
I mean, the stapedial artery itself is extremely rare, right? And so, like, even we just start asking ourselves, why is that so rare? Like maybe like like the step of annexation of the middle meningeal artery from the external carotid artery is probably like such a key step, maybe, or a step that happens in such a key moment of the embryo development that it's extremely rare for it not to happen, meaning that if it doesn't happen, maybe the embryo doesn't even get to our to meet us,
Yeah, I think the whole genetic component of this is still like in development, right? It's really don't know too much about that. Morphologically, it is what it is. But yeah, and both, like as Kitty Pong you mentioned, like maybe this guy has phases too, and this is just part of somehow this is something that we still don't know. Okay, so anything else? If not, I want to thank all the presenters. Thank you all very much for your time, your participation. And of course, again, congratulations to all the fellows. We are, we're here to help education, and I think there's just so much. You can see the different presentations, the breadth of what people are interested in or involved in. That's like a big testament to our field as well. We are growing in terms of what we can do and what we do. Again, venous sinus, MMA, all of that stuff has emerged or has been emerging, in the past couple of years, has been gaining steam. So we hope that continues. There'll be more things for us to do and a bigger scope of learning. Okay, so again, next week, we'll see you next week. We'll see everybody next week. There's going to be an introductory session for the newcoming fellows, and then we'll go to once a month. So we're planning to do the first Tuesday of the month to stay in the 8 to 10 schedule. And if there's any suggestions, comments, please, email. You get the newsletter if you sign up for the newsletter through Bananas. But you can email newranger@newranger.org. This is going to be recorded, so you see the recording of that session. And again, thank you to all the presenters. Thank you so much.
Thank you.
We'll see you next week. Bye-bye.